Welcome. We'll start promptly at noon. Thank you for helping us kick off the MDH Stroke Program monthly education series. Stay tuned for an email or calendar invite for different education opportunities, trainings, or webinars that will be available every month. We're excited to start off the new year celebrating the 2021 Stroke Quality Improvement Award recipients. If you need to leave early or want to watch this presentation again later or share it will be recorded late and available later. As usual, your lines have been muted upon entry. Please ask any questions by typing in the chat throughout the presentation. Just make sure that everyone is selected to receive the chat so we can all see the question. And we'll keep track of these and try to address them at the end of the presentation if time allows, or it'll be with the follow-up email that you get a few days after this webinar. So on to the agenda today. We're going over the objectives for today's presentation. We'll briefly review the Stroke Quality Improvement Award Program, announce the award recipients, and the majority of the time will be dedicated to our award recipients who will be showcasing their projects. Today, we will understand the purpose of the MDH Stroke Quality Improvement Awards Program, discuss the benefits of collecting and using data for quality improvement at your hospital, and learn about methods and approaches hospitals took to conduct their quality improvement projects. Before we jump into the award recipients, let's just quickly review why we have this program. So we know most of you are conducting a quality improvement project to some degree. We just want a chance to recognize you and to share how hospitals around the state are tackling different initiatives. This award program aims to recognize and showcase successful quality improvement initiatives throughout the state of Minnesota's hospital-based stroke programs. On top of that, we want an opportunity for hospitals to share their successful quality improvement projects and lessons learned to further a culture of learning and collaboration. And lastly, we want to encourage others to take on projects and also apply. I hope that if you applied last time and did not receive an award this round, you're not discouraged and you keep applying. No matter who wins, we celebrate each other's victories and successes because it means good things for all Minnesotans. So awards are given to hospital stroke programs that implemented the best quality improvement initiatives in the following categories: Continuous Impact Award, Operational Excellence Award, Outstanding Achievement Award, and we'll review each description of these categories during the showcase portion of the webinar. If you're looking for more inspiration after today's webinar, please check out our Stroke Quality Improvement Awards page on our program's website. You can read about 2020 and 2021 award recipients. And this is also where you'll find eventually the Stroke Quality Improvement Awards page, an application that's coming for 2022. Now we've come to the celebration portion of the webinar and what we've been waiting for, the award announcements. It gives us great pleasure to announce there are 7 awardees for 2021. All award winners are designated stroke hospitals through the Minnesota Stroke System. 6 of the hospitals are located in the state of Minnesota, and 1 is located near the North Dakota-Minnesota border. While not technically in Minnesota, this neighboring hospitals initiative positively impacted many Minnesota residents. Our first category is Continuous Impact. This is being presented to Maple Grove Hospital, Essentia Health St. Joseph Medical Center, and Mercy Hospital, part of Allina Health. Next, we have the Operational Excellence Award. This is being presented to Regions Hospital and Sanford Bemidji Medical Center. Lastly, we have the Outstanding Achievement Award. This is being presented to Sanford Medical Center, Fargo, and M Health Fairview System. Congratulations, hospitals. We'll now move on to spotlight each of these awardees and hear a brief summary of their project. And we're lucky enough to be joined by every single one of them. We will start off with the Continuous Impact Award. This is an award for starting an initiative that created a meaningful and long-term improvement in quality of stroke care. First up, under the Continuous Impact Award is Maple Grove Hospital. They are an acute stroke ready hospital located in Maple Grove, Minnesota. And today we have their stroke coordinator, Morgan Hill, to talk about their QI project. Take it away, Morgan.
Hi, my name is Morgan, and I am the stroke program coordinator at Maple Grove. As Allie said, we are an acute stroke-ready hospital. Since the start of the stroke program at Maple Grove, the primary focus has been within the emergency care center. The majority of our patients with a stroke-related diagnosis were then transferred to a comprehensive stroke center. In 2019, we admitted only 2% of our stroke patients, but as we know, everything changed in 2020. While our emergency care center visits decreased, our stroke volumes actually stayed the same, seeing only about a 3% decrease in patients with a final diagnosis of CVA or TIA. What did change is that we began admitting these patients to our facility. In 2020, we admitted 13% of our stroke patients. In reviewing this new population of admitted patients, I realized that we were not providing these patients with all of the recommended discharge education or completing a modified Rankin score at discharge. After some research, I realized that it seemed to be more of a lack of awareness of the requirements, as well as not knowing how to document the information that our nurses did provide to these patients and their families. Knowing this, I decided to use Stroke Awareness Month as a jumping point for education for the inpatient nursing staff. Over the month of May, I personally attended all of the Med-Surg and Intensive Care Center team meetings. I provided information on stroke awareness, our stroke team stat process, as well as documentation, education, and reminders. I also created education that was sent to the staff who were unable to attend the meetings. Modified Rankin practice questions were added to the team newsletters. I think that one of the biggest impacts were actually poster boards that were created. I put together multiple different boards and placed them at the main employee entrance and in the ICC and Med-Surg break rooms. These boards included information on stroke awareness, types of strokes, tips and tricks related to stroke care and assessments, documentation requirements, and patient education. The information on these boards, as well as the boards themselves, were rotated frequently throughout the month, so essentially each week there is new information. Additionally, I completed real-time audits when able. I would try to touch base with the nurse who is currently caring for a stroke patient to make sure that they were aware of what needed to be completed. Lastly, I started sending emails to the nurse that discharged the patients, as well as their nurse manager, after each stroke patient was discharged. I thanked them for providing great care and let them know if they'd missed any of the required documentation. If the discharge education and Rankin scores were not done, I let them know that it was missing. In those situations, I also sent a quick reference tip sheet on how to complete the documentation in case they were not aware of how to do it. We still have a lot of work to do. With the small number of patients that we admit, a nurse may only discharge a patient once or twice a year. This is addressed by providing additional education to our patient care facilitators or charge nurses, who can remind the discharging nurse to complete the required documentation. The good news, our patient education has increased more than 400% in the few months following this rollout. For some reason, our documentation of our modified Rankin score has not really changed, so that's an area that we're going to need to do a little bit of further education. Lessons learned, I think repeated reminders and exposure to stroke requirements that were done during the Stroke Awareness Month were really beneficial to the staff. Everywhere they looked, there was some sort of stroke information for them to learn about or to review. And I think that these repeated friendly reminders had a positive outcome for our patients.
Thank you so much, Morgan. Next, we have Essentia Health St. Joseph's Medical Center. They are a primary stroke center located in Brainerd, Minnesota. Joining us today is their stroke coordinator, Elsie Stanek. Welcome, Elsie.
Thank you. So our stroke program focused on the assessment of the modified Rankin scale. We identified this focus area as important as it can help assess a stroke patient's functional outcome. Its significance was also noted in the updated rehabilitation performance measures for primary stroke certification. When evaluating our stroke patients and program, we acknowledge that this was an area needing development. Our therapy department had recently initiated assessing the discharge modified Rankin scale before it was required. However, the pre-modified Rankin scale was an additional assessment that we found needed addressing. Therefore, our action plan goal was twofold. One, to initiate the assessment of the pre-modified Rankin score, and two, to audit both the pre and discharge modified Rankin for compliance. Our action plan included multidisciplinary communication to determine who would best capture the largest volume of admitted stroke patients and who was best qualified to assess and document the modified Rankin. After this was determined, our electronic medical record was updated so documentation of both the pre and discharge modified Rankin could be complete. During this time, staff was educated on the modified Rankin and updated documentation requirements. Once these tasks were complete, staff began to assess and document on all admitted stroke patients, and charts were then audited for compliance. Next slide, please. This quality improvement plan was initiated during a difficult year with COVID, which caused some delays. However, our team learned with good communication, teamwork, and flexibility between team members, success can still be achieved. After some adjustments were made to our initial action plan due to delays, our program was able to initiate both the pre-modified Rankin assessment with documentation in the electronic medical record. As we can see on the graph, significant improvement has been seen with the pre-modified Rankin scale compliance. We can also see consistent compliance with our discharge modified Rankin scores. Last of all, during this project, we learned with one successful QI project, another potential quality improvement plan can be found to better care for our stroke patients within our facility.
Thank you so much, Elsie. Wonderful. And to finish off the continuous impact award category, we have Mercy Hospital, part of Allina Health. They are a primary stroke center located in Coon Rapids, Minnesota. Please welcome Dawn Kraus, their stroke coordinator. Hi, Dawn.
Hi, thank you so much for letting me present our work. So this is a picture of a small representation of our team who helped in this project. Next slide. And that was to meet the compliance measures set by the DNV for our door to alteplase, door to needle times. We had most often met at least 75% of our cases being less than 60, but we were not compliant with 50% of our cases being less than 45 minutes. So our whole stroke program committee agreed that this was our area of focus. We changed everything about our stroke code. The stroke code, when it was called by a patient coming in via EMS or private car, the immediate page went out to the stroke neurologist. This was a change from previous where our ED physicians would not page the neurologist until after the CT or CTA images were obtained. Now the stroke code was called and the neurologist was paged. The patients, when they came in via ambulance from the EMS bay, would go straight to CT with not even getting off of the gurney. We would try to facilitate the fastest times to CT. That was a big change and uncomfortable for our ED staff. We also implemented telestroke carts, and that allowed the stroke neurologist to meet the patients in the CT suite and do a mini exam on them before the CT. And then the radiologist would call the results directly to the stroke neurologist rather than to the ED physician. We clearly defined the roles for every staff member that had that touched this stroke patient in this process. And we did training. We had classes for all ED nurses, pharmacists, CT techs, and ED physicians. And then we reviewed cases after they occurred to identify where we could improve the process. Change is hard, and this was hard for us. And as an example of that, when the neurologists were doing a mini CT or mini NIH stroke scale exam prior to CT, that extended the door to CT times by a few minutes. And the CT techs balked at that because they were focused on keeping their door to CT times low. That was what they owned, and they did not want that time to increase. So once we demonstrated that the overall treatment times, the overall door to needle times was decreased because a neurologist could make a faster decision once the images were in, it helped the CT techs to see the overall process and be proud of the part that they played in facilitating faster treatment. So our results have been fantastic. Our door to needle times have decreased by an average of 9 minutes. And you can see how in 2019, we were only about 60% compliance with our less than 60 minutes. Now we are 78%, but our cases less than 45 minutes has increased by double. We are now 62% compliant at the end of 2021 and are starting to measure and cases less than 30 minutes, which is a totally new territory for us. So thank you very much.
Thank you so much, Dawn. The next award category is Operational Excellence. This is an award for an initiative that focused on collaboration between different programs to improve quality of stroke care. First up, under Operational Excellence Award, we have Regions Hospital. They are a comprehensive stroke center located in St. Paul, Minnesota. Joining us today, we have Carol Drogemiller, Andrea Shilby, and Alicia Vars.
Hi, everyone. I'm the Stroke Program Coordinator at Regions. This is Carol, and I want to thank you, Allie, and the MDH team for your recognition and support of the Stroke Quality Initiative we are sharing with everyone today. Regions Hospital Emergency Department sought to improve the translation of the pre-hospital care record, the PCR, from the emergency medical services teams, the EMS, to the electronic patient record. The photo that you're looking at features a sample of the persons involved along the way and highlights the different areas that contributed to the process improvement, including the Multidisciplinary Stroke Center Committee, which had representation from Quality Department, Emergency Department, and EMS, the Health Information Management Department, and the ED Coordinator Group. The Emergency Medical Services, or EMS, Pre-Hospital Care Record, or PCR, is an essential document for understanding the status of a patient prior to the arrival to the stroke center and is required by Minnesota Statute 144E.123, which states that if a patient is transported to a hospital, a copy of the ambulance report delineating the pre-hospital medical care given shall be provided to the receiving hospital. So as you know, the PCR contains the patient's story, vitals, medications, assessments of the patient, such as the Cincinnati Pre-Hospital Stroke Scale and time last known well.
Hi, everybody. I'm Alicia Vars. I'm one of the supervisors in the emergency department. I'm also the EMS liaison that worked with Carol and Andrea on this project. So prior to the project, our process for receiving PCRs was the paramedics submitted the PCR to Regions via a fax machine. So some within the day, others took longer. The coordinators would receive the fax, label each form with the patient information, make copies, and then one of those copies would go to HIM, and then one would follow the paper record through the patient's discharge. So during this process, we had identified that only 64% of the stroke patient PCRs were actually making it into the electronic healthcare record. Therefore, we sought out a process improvement initiative to optimize how the PCRs were uploaded to the health records. So through the partnership between the Stroke Committee and the Emergency Department, we opted to implement an upgraded system called WriteFax. WriteFax allowed us to simplify the process to one reliable intake method, removing some of that paper printing and manual process, and contributed to consistent capture of PCRs.
Hi, everyone. I'm Andrea Shelby. I'm a clinical nurse specialist in the emergency department at Regions, and I was also part of this process improvement. So I'm just going to go over some of the successes and lessons learned. So through this process improvement, we found successes in our multidisciplinary collaboration, as well as improving other programs and populations in their PCR translation. Additionally, a dedicated liaison position for EMS and emergency department was created to provide feedback and problem solve the various PCR electronic platforms. The combined changes led to reliable PCR translation in 95 to 100% of stroke patient records for many consecutive months. Lastly, we had many lessons learned. While the implementation of the WriteFax primarily showed promise for improved capture of PCRs, it was not until the focused attention and partnership with the emergency department liaison that our goal was achieved and sustained. Additionally, these system changes went on to positively impact our non-stroke case PCR capture for the entire hospital. We all agree that this project demonstrated how applying sound quality improvement principles, such as understanding the current process, stakeholder engagement, problem and data analysis, designing future state, and tracking and reporting results, yielded the desired outcome. It encourages similar partnerships when conducting future quality work for other initiatives. Thank you.
Thank you so much, Carol, Andrea, and Alicia. We appreciate your time. Wrapping up our Operational Excellence Award, we have Sanford Bemidji Medical Center. They are an acute stroke ready hospital in Bemidji, Minnesota. We have their stroke coordinator speaking today. Please welcome Amy Bukanaga.
Hi, this is Amy. I'm sorry, I was in the middle of another meeting at the same time. So my RQI project was improving care through communication with EMS. And you could switch that. This project was built off of work started by the time critical collaboration Northwest project. And I really need to get a shout out to the hardworking, dedicated individuals on the EMS team who took the information that I provided on the feedback forms and then actually implemented the changes in their departments. Our collaborators were the Bagley Ambulance Service, the Bemidji Ambulance Service, the Black Duck Ambulance Service, the Leech Lake Ambulance Service, North Memorial Health Ambulance Services, Brainerd and Walker Park Rapids, and then the Red Lake Ambulance Services, but I didn't have a picture of them. The aim of this project was to determine the level of adherence to evidence-based stroke and to work with the local EMS agencies to improve their practice as necessary. We looked at stroke assessment completed, stroke alert activation, IV access obtained, EKG obtained, glucose obtained, and last known well documented. And then reviewed all the cases that EMS brought in. And if there was a code activated or not that ended up with a stroke diagnosis, and tried to give them feedback within 30 days. And you can switch the slide. Successes that we saw, definite improvement in all pre-hospital stroke measured metrics. They also had much improvement in their documentation. We had better communication between the EMS and the medical staff when they were doing their handoffs. We had lessons that we learned was that we needed to really have feedbacks on forums still doesn't take away from that face-to-face communication. But with COVID, we were only really able to have one face-to-face meeting in we had one in 2021. If you have few cases, a missed opportunity will greatly affect your result, and that was vice versa. And that timeliness of the feedback was really important to actually see them make a change. Our average turnaround time for their feedback in 2020 was 26 days. And then, but in 2021 with COVID and getting pulled to other duties as assigned, I'm back up into the 50s. You can go to the next one. In 2021, EMS called the code 80% of the time on cases reviewed, and they had 174 cases that I reviewed for EMS, 140 stroke code calls, which was up from 68% in 2020. It was also increased. They brought in 60 more cases in 2021 than they did in 2020 with strokes. And you can see a definite improvement in if they activated the stroke or not. Next slide. Last known well documentation. In 2020, they were at 64 4% of if it or not. In 2021, they're averaging about 75%. So again, a significant improvement. The other thing is they're documenting actual last known well, not just symptom onset, which has been really helpful for our providers. And then my next slide. This was just to give them an idea where we were on all the elements that I was looking at and sending to them. And it's, you can still see we're trending upward. We're still not close to where we want to be, but in 2020, they were at 22% of getting all the elements we were looking at for a stroke code documented on their run sheet. In 2021, they were up to 44% of meeting those elements. So again, they are just making improvement, and it's been really great just seeing them question whether or not should they have done something different, what could they have done better. I just think EMS has just been wonderful in soaking up the feedback and trying to change how they are caring for the stroke patients that are out in the community. Any questions for me?
Well done,
Thank you.
Amy. We'll send you any questions. I know you have another meeting to jump to, so we'll send any questions through an email to you and get them responded.
I'm done with my meeting. We
Oh,
hurried
great.
through it, so I'm going to be on listening to the rest.
Perfect. Thank you. Well, we're going to move on to our last category, which is Outstanding Achievement. This is an award for starting an initiative that created a meaningful and long-term impact in the quality of stroke care. First up, for the Outstanding Achievement, we have Sanford Medical Center Fargo. They are a comprehensive stroke center in Fargo, North Dakota, and we have their stroke coordinator, Holly Nissen, sharing with us today. Hi, Holly.
Oh, thanks so much for having me. This is super exciting. So we focused our project on reducing stroke mortality. So to give a little background, our goal was to decrease the stroke-specific mortality index to below 0.8 in 2021. And our stroke team developed a performance improvement project focusing on initiatives to decrease that mortality of our both ischemic and hemorrhagic stroke patients. We took a few actions, and we found that we had some opportunity to improve our documentation. We invited some of our coders and into our meetings, and they provided tips and tricks to our physicians. They also reviewed our physician and APP documentation for specific documentation opportunities that reflect the acuity of our stroke patients. We began to educate the ED physicians on our support of our palliative care team and our palliative care unit to make sure that we are getting those consults in and moving those palliative care appropriate patients to those consulted teams. We launched a new telestroke platform where we can do secure video visits with patients and their families from other facilitation or other facilities, and we can talk about or give second opinion if there is the event of a devastating acute ischemic stroke or hemorrhagic stroke. So with this information, we monthly reviewed all of our mortality cases at an M&M review case conference and found opportunities for improvement in their care, reviewed that with our team and implemented those. We then reported all of our data at the Multidisciplinary Stroke Task Force, as well as our Mortality Stroke Task Force and our quality leadership team on a monthly basis, just to go over the progress that we were making in this performance. So during our analysis, we found that using a combined approach to increase the acuity of our patients through documentation, as well as utilizing one-call, AMWEL, our palliative care teams, and we were able to find that it could affect both sides of the observed as well as the expected mortality index for our stroke patients. So metrics, as you can kind of see on this, it's kind of small, I apologize, but after the implementation of our quality improvement plan, we experienced the lowest mortality index of our stroke patients for the first quarter of 2021. We dropped our neurology mortality index to 0.5 and had 0 mortalities in the month of February, despite the increase in our case mix index. And that just shows the acuity of our stroke patients. We continued to see our trend line decrease towards our goal into 2021. And in the second quarter, our neurology was down to 1.03, and our overall year index was down to 0.77. So we also, of note, had no hemorrhagic mortalities in July and August. So next steps, or as our continuation of this work goes, is we continue to have our clinical documentation specialist teams come and do tips and tricks every department meeting. They also do that physician feedback, and we do continue to report out all of our metrics at the stroke task force meetings, mortality, and our quality leadership team. So excited to continue this work.
Thank you so much, Holly. Finishing up our Outstanding Achievement Award is the entire mHealth Fairview system. All hospitals listed here were involved in the project and contributed to their success. I'll spare you and not read each one, but as you can see, it involved multiple levels of designation over a large surface area. So Sarah Anker, their Cerebrovascular Services Manager, is here to talk about their project today. Welcome, Sarah.
Hi, thanks. Thanks for the recognition and the opportunity. I apologize, I'm a little under the weather, so hopefully my voice is coming across all right. So you can go ahead and go to the next slide. In 2020, we undertook a very large scope project to develop an optimal care pathway or care map for all acute ischemic stroke patients within the mHealth Fairview system, really spanning the continuum of care from when the patient entered the emergency department through discharge from any one of our 9 mHealth Fairview hospitals. And really the overall purpose of the project and our goal was to reduce clinical variation and ensure that regardless of location, patients were receiving care that's consistent with best practice standards established by American Heart Association, American Stroke Association, and current clinical practice and evidence-based research. So our project kicked off in January of 2020 and actually spanned the entirety of 2020. And we actually went live with implementation in February of 2021. One of the lessons learned was that a pandemic slows things down, but also our timeline, we really had to adjust several times because I think we, maybe underestimated the initial scope and impact of the work. To develop our stroke care map, we engaged a really large cross-functional, multidisciplinary stakeholder group. So we had representatives from all of our mHealth Fairview sites, a variety of disciplines, so pharmacy, neurology, emergency medicine, nursing practice and education, informaticists, acute rehab, our rehab services, our stroke program coordinators. We all came together and worked over the course of about 3 months to actually develop the care map and come to consensus and agreement on what our mHealth Fairview best practice standards were going to be. And from there, once we had determined and developed those standards, we went about with implementing them, and much of that work with standardizing our clinical practice across the system was done through order set standardization. And that work really took a long time. You have to have a very keen eye for details, as many of you know, when you set about updating order sets. I think we started off the project with around 20 stroke order sets that were being used across the system. We were able to archive and retire approximately 10 order sets. And really what we ended with was a standardized group of stroke order sets specifically for patients in the emergency department, patients that are admitted to our medicine units, and patients that are admitted to our ICUs. So at this point, we have all sites across the system using the same same order sets, and they're standardized for ischemic stroke patients. And again, those order sets were reviewed and updated to ensure that they meet current best practice guidelines as I mentioned earlier, established by the AHA and ASA. In addition to ensuring that those standards were met through order sets, we also standardized our stroke code process in the emergency department. This was probably one of the biggest challenges there, although, you know, we are all working towards a common goal with, you know, quickest possible door to thrombolytic time. There's variability from site to site with respect to availability of resources, staff, kind of, you know, historic practice. And so we really had to develop a stroke code process that would account for all those variables across the system. And so we did that with a tiered stroke code process. So our tiered stroke code process, we have patients who exhibit stroke symptoms, whether they arrive via EMS or walk in, if they're within that traditional thrombolytic window of 4.5 hours. We empowered all of our nursing triage staff across the system to go ahead and activate a stroke code upon arrival for those patients that fall within that traditional thrombolytic window. The next tier of patients are patients that fall outside of that 4.5 hour window, but again have acute new onset stroke symptoms. Those patients receive a stroke evaluation by the emergency department provider, and the emergency department provider determines whether or not we should proceed with a stroke code. So if the patient has disabling deficits, NIH, high NIH indicative of a potential LVO, they'll go ahead and activate a stroke code. And if patients with a lower NIH, non-disabling symptoms, they go ahead and request a stat stroke consult and move quickly to imaging. In addition to the tiered stroke code process, we also transitioned to a system-wide standard thrombolytic using tenecteplase. There's been a lot of interest in that, and that has gone very well and represented, you know, not only an opportunity for us to improve our door to thrombolytic times, also represented an opportunity for cost savings, and I think, you know, has an improved profile with respect to ease of administration. So that was another big achievement with the stroke care map. Other strategies included early mobilization following thrombolysis. So we shortened that bed rest period in the hopes that that would also positively impact our length of stay, mobilize patients earlier, and get them going on their therapy and road to recovery and discharge. And then we also expanded our screening to ensure that all sites have screening for acute rehab eligibility. And so regardless of location, our acute rehab liaisons, which are our nurses, screen all patients across the system to really try and identify those patients that aren't immediately obvious as a candidate for acute rehab and try and increase utilization of acute rehab for recovery. Next slide. So since February 2021, we have impacted the care for over 1,100 patients within our system. Our order set utilization, which again, we're really trying to drive and get at our standards through order set usage, improved from 59% to 74%. We've achieved reduction in our excess length of stay, down to 0.68 days, reduction in our 30-day readmission. To date, and this is current as of the end of 2021, we have had more than 200 patients that have received tenecteplase. Our symptomatic ICH rate remains less than 1% in those 200 patients. So we're really proud of that work and the safe transition that we were able to make. And then that transition to tenecteplase represented a significant cost savings for our system as well. I think as far as lessons learned, this is really a good opportunity to really give a shout out to all sites, all of our stroke champions across the system. This was a very large scope project, and our engagement was amazing, particularly considering that we kicked off this work basically at the start of the pandemic. So we're particularly proud of everyone who had a hand in this project, and again, hats off to all of those representatives across the site. I think our biggest success was our collaboration, and as far as lessons learned, I think the biggest lesson was being okay with adjusting our timeline if it ensured that in the end, the right work was able to be completed and accomplished. So rather than having that focus be on a deadline, we were flexible with that, kind of gave ourselves some grace, and with that extension, I think we're able to, really make a significant impact and improvement in the care for patients across our system and across the state of Minnesota. And that's all that I have. Thanks.
Thank you so much, Sarah. Well done. And that brings us to the end of the presentation today. I just hope that everyone comes away feeling very proud of their work, and it really blows me away what everyone was able to accomplish despite the odds this year. And so I just want to say thank you so much to the presenters today. Congratulations again. That concludes today's webinar. Michelle will put the evaluation link in the chat to receive contact hours. We really appreciate your time today and listening to everyone share their projects. It's a great opportunity for us to learn from each other. You will receive a follow-up email with the recording, evaluation link, and slide deck. Please contact me with any questions, and I hope to see your application this year so we can recognize you for the 2022 Stroke Quality Improvement Awards. Thank you, everyone.